Hello all. Today we'll be discussing a case of laparoscopic tubal recanalization, that is tubal reanastomosis. Myself Dr Pradeep Ingale, consultant gynecologist at Snehadeep Super Specialty Hospitals, Ahilya-Nagar, Maharashtra. So to begin with, the procedure begins with diagnostic hysteroscopy. She was a case of previous to cesarean. She was a 32-year-old lady who lost her son because of blood cancer at the age of 8 years. Now you'll see in this lady the tubectomy was done during cesarean section. So the first step is infiltration of the diluted vasopressin solution into the mesosalpinx. So it will drastically reduce the vascularity temporarily so that we can safely cut the tube. So fibrosed ends of medial and lateral ends of tube are cut with cold scissors so as to refreshen the edges. Middle portion of the fibrosed part of the tube is removed. Patency of the proximal end is tested with methylene blue dye. Patency of the distal end is confirmed with methylene blue dye. Now we'll be approximating the mesosalpinx so as to bring both the cut tubal ends together so as to achieve tension-free suturing. So the suture here we are using is Vicryl 40. We prefer Vicryl because it is surgeon-friendly suture. It is easy to handle during laparoscopy. The first suture we are taking is at a 6 o'clock position. Now the suture goes from outside in distal part and inside out in proximal part. So we usually take 3 to 4 sutures. We prefer to take sutures through the tubal lumen as we believe that these sutures would remain there for 6 weeks and these sutures would act as a scaffolding over which mucosal lining would grow. So 3 such sutures are taken and first 2 sutures are left without tying a knot and last suture is tightened, following which the remaining 2 sutures are tightened. The knot is cut near to the suture and as you are seeing, almost every knot is a true knot. So there is no much crushing of the tissues, only approximation is achieved and we need to be very gentle. So all these 3 sutures are tightened. Now mucosal approximation is done. Now pouting mucosa is approximated. So in this case the good part was that the tube was cut in the midline. So in all such cases the reversal surgery can be achieved in a nicer way as the tubal misproportion is less. So we are trying to bury the mucosa. As we all know, the distal part of the tube is thicker one or broader one and proximal part of the tube is thinner one or smaller one. So as to bury the mucosa we are taking these sutures. So this was a first layer of suturing. Now we'll begin with second layer of suturing, which is serosa to serosa approximation so as to bury the first layer. Now this layer is not must, but we usually take it so that we can bury effectively all the raw area. So there will not be any adhesion formation and tubal health would be good. Again, same tension-free suturing is done. Serosa to serosa approximation is done so as to bury the raw surface. As you are seeing, we are taking intermittent sutures. We are not taking continuous sutures so as to reduce the tension on the suture line. from distal end to proximal end. The instrument we are using here is a set of 3 mm Maryland in my non-dominant hand and 3 mm needle holder, non-tooth needle holder in my right hand. So Maryland offers a very good grip over a needle. 4-0 needle is a very tiny needle to handle. So you need to be very gentle while handling this needle and suture. If you pull it too tightly, it will cut through. So few sutures are taken at 6 o'clock so as to bury the mucosa. The principles of microendoscopy remain the same for suturing. So there should be minimal tissue handling. We need to achieve a very good hemostasis. We should achieve a tension-free suturing, and there should not be any exposure of the tissue, or tissue should not become too dry. So in laparoscopy, as we are working in a closed system, so there is no question of drying of tissues. We get magnified picture, almost 20 to 30 times magnified picture is seen, and with laparoscopy the tubal reanastomosis as compared to open surgery, they are far better. Mesosalpinx is sutured and left tube is almost done. Now the similar steps are repeated on the right side. We are injecting diluted vasopressin solution into the mesosalpinx. This will drastically reduce the vascularity. While injecting vasopressin into the distal stump, you should avoid the vessels, as the distal part is generally very vascular. Now around tube is cut 0.5 to 0.7 millimeters away from the cut part so as to avoid fibrosis. And as far as possible, try to take a single bold nick. As you take the nick, the usually mucosa pouts out and you get a very good margin to suture. Now fibrosed middle portion is again removed. You should always confirm patency of the distal and medial ends. Sometimes with age, with PID and all, the distal or proximal ends, they are blocked. Now you may see the distal end is open. So with for tuboplasty we use methylene blue dye, and we don't dilute it too much. As you are seeing, when we are testing the patency of the proximal end on the right side, we can also see the dye has came from left tube also. Again the approximating sutures are taken. Now in good selected cases, this surgery is very rewarding. The most important factor in this success of this surgery is age of a female partner. If age of a female partner is less than 35 years and if she is having a good ovarian reserve with at least with a good sperm count, you can achieve a success rate of around 70 to 80% with this surgery. Now there are few distinct advantages of this surgery over IVF, as this is a one-time procedure and couple can achieve n number of pregnancies after this surgery if it becomes successful. Second thing is, in IVF there are high chances of multifetal gestation and you need to take n number of injections and it is more invasive. As compared to this tubal reanastomosis, you can achieve a pregnancy in a natural manner. Again, the suture is passed outside in, and now the suture will be passed from inside out to the proximal end. Now, as I already told, we believe in passing the suture through the mucosal layer. So we believe that this suture acts as a scaffolding. Now there are few studies wherein only single suture was applied from mucosa to mucosa, and this gave the author a pregnancy rate of around 50%. So in a properly selected case, the chances of getting pregnancy are very high. So we usually use 3 sutures. Now this is a 10 o'clock suture, and third suture is taken at 2 o'clock position. As I have already told, we don't tie the sutures first, just we pass the sutures and cut the thread, and when the last suture is done, then we start tying the thread. Again, tension free suturing is done. Now remaining sutures are tightened, and see, we are always tying the true knots. Be gentle, don't crush the tissues. In India, the commonest reason when this surgery is performed is death of generally a male child. So this lady had lost her son because of blood cancer at the age of 8. Fortunately, she is young. Count of husbands are normal, and in all such cases the results are good. So 70 to 80% of the couple, they'll conceive in 1 year. So after the surgery, you may advise them to plan for pregnancy after 6 weeks, when the sutures will go off. As in this surgery, you should also counsel the couple there are chances of ectopic pregnancy, especially when we find that if the tubes are too distally cut, the chances of ectopic pregnancy are high. So in our series of more than 50 cases, our success rate too is more than 80%, and we had only one single case of ectopic pregnancy. So you advise the couples timed intercourse. There is no need of any ovulation induction and all. If the count is good, if the tubal patency achieved is good, there is no need of any ovulation induction. You may just simply ask them to have a timed intercourse. Majority of them, they'll conceive in 6 to 8 months. So if at the end of 1 year, if they fail to conceive, then you may go for HSG and then accordingly decide what needs to be done. Second layer of serosal suturing is done so as to bury the mucosa. As I already told, there is no need of the suture, but we usually take it so as to avoid adhesion formation, and the mucosa remains inside. At least 4 to 5 centimeter residual tubal length has to be there. If the residual tubal length is less than 4 centimeters, then the success rate drastically goes down. As compared to open surgeries, the success rate is better when the primary surgery was done laparoscopically, because the tubal loss is less with tubal rings. Usually the success rate is better when the tube is cut in midline. The more distal you go, the difficult the surgery becomes, because the luminal contours are different. So they are very difficult to approximate. And even if you approximate, the chances of ectopic are very high. So this 6 o'clock suture is taken. And when at least you have passed one suture from lumen to lumen, when there is no need of watertight closure, even if the dye doesn't come, you may see we have achieved patency of both the tubes. So even if dye doesn't come, it doesn't decrease your success rate. So both ovaries are healthy, both tubes are healthy, and we have done our job. Wishing success to her. Thank you very much.